Latino workers in California.
Okay.
Yeah, we're one of the many exposed. You know, they've suffered really badly, particularly in California. If you were going to look at a particular ethnicity that really has borne the brunt of this disease, it's been the Hispanics in California, because they do all the couriering, the truck driving, all the exposed, you know, all the construction work. They're the ones who are at the coalface.
I thought it might have been New York, but
yeah, no, I mean, of course, yeah, New York too, yeah, but New York's more of a lower socioeconomic impact. It's people in public housing estates. It's the elderly in aged care, exposed workers. California's more really workplace orientated disease. It's very, very similar to Melbourne. Same story, unfortunately.
okay, people are joining, but I think we'll give them 2-3 minutes
Yeah.
before we sort of make a start. And
That image you used there, Nick, looks like an iconic image from New York.
yeah, well, Costa selected it. And,
Yeah, Costas. Early 1900s, late 1800s.
Yeah, I wanted to find something that I guess showed a lot of people of the new migrants huddling together, which is perfect grounds for.
That's right, exactly. Spread.
For spread, yeah.
reminds me, is there a film sort of Gangs of New York? That's what it sort of reminds me of. And,
That's right. You had Irish in the mid to 80 to sort of up to about 1870, and then you had the Europeans, you know, Poles, Greeks, Italians, Germans. Germans were a bit earlier. Lots and lots of Greeks in around the turn of the century in the US. Trace a lot of my DNA there, actually.
we'll give it another minute and then we'll make a start. And, okay. Costa, you going to make a start?
Yep.
Kalisperas, good evening, everyone. Welcome to the Greek Community of Melbourne Public Seminar Series. This is our 6th online sort of seminar for the year, and the program will continue probably at least until the end of November. Definitely as long as this lockdown or partial lockdown is in place. A big welcome for those who are tuning in for the first time. either through Zoom, Facebook, or YouTube. And I just want to remind you all that for those that have registered via Zoom, you can use the chat function to ask questions. Just before the end of the seminar, I will put in the call for questions, and we'll be able to put them to the speaker at the end of the presentation. Okay. Let's get to the heart of tonight's topic, COVID and its impact on migrant communities. It is clear that COVID-19 pandemic is affecting some more than others and has been one of the most far-reaching crises of the past century, disrupting the lives of communities around the world. As it spreads around the region and the globe, it is noticeable that the virus discriminates, affecting some communities more than others, exposing existing inequalities and fault lines in our societies. It takes a heavy toll on the poor, the homeless, and those without access to adequate health services. On the front line of exposure to COVID-19 are millions of migrant workers. Many of these migrant workers and refugees and internally displaced people among the most at risk from COVID-19, as well as its socioeconomic fallout. Migrants and refugees often struggle to access proper healthcare due to language barriers or lack of culturally appropriate care. Many of them are not afforded the luxury of working from home. The occupations often involve being mobile or being in a close vicinity of other people, basically making them more vulnerable to the exposure of the virus. They are disproportionately represented in the statistics of COVID fatalities and remain a very vulnerable cohort. Tonight, we're honored to have with us Kosmos Samaras, an analyst, statistician, commentator, and many other things. He wears many hats from what I can see. He'll be examining this fatal confluence of COVID exposure and migrant fatalities. A bit of background on Kos. He grew up in Melbourne's migrant working-class suburbs of Northcote and Broadmeadows, and his parents migrated to Australia in the 1960s. His working life in advertising and politics spans almost 30 years, and 14 of those was Victoria Labor's Deputy Campaign Director, where he specialised in political and social demography. Presently, he runs a research consulting company that focuses on both social and corporate projects aimed at assisting the broader community. Enough for me. I'll just pass on the baton to welcome Kos.
Thank you. So I'm just going to take you through, obviously, the subject of tonight, which is the impact of COVID and on the migrant communities around the world, and obviously expand on the many points that Nick just introduced us to. So that's a very quick introduction for me. So I might just start the presentation and we can kick off, I guess. Just bear with me. Full screen just doesn't seem to be working.
You need to start the presentation. I don't know if you have done that yet, Kos. From the bottom right. Yep.
Yeah, there we go. Much better. Apologies. Took a while. Okay, so I'll take you for a bit of a journey around the world in terms of just how COVID has actually impacted migrant communities in different ways. So it's not just necessarily about the work they do and how they're exposed. It's not just about the homes they're living in, the size of their families. It's their status in life. And I'll take you through the journey. We'll go around the world and then obviously come back here to Australia, and in particular Melbourne, which if those of you who do live in Melbourne would be acutely aware of just how devastating this disease has been on, in particular, the Greek community. There is a connection between that precarious workforce and the aged care centres. And you can't separate the two when it comes to any pandemic. And I'll take you through the journey in that space. So before most of us actually were alert to this pandemic and the disease that it was going to present us for, well, the entire 2020 calendar year, unfortunately. COVID had obviously started in Wuhan. There's still obviously debate in terms of where it originated from, but it's probably the first major breakout was in Wuhan, at the wet market in that city. Before they had a lockdown, to give you some context in terms of how it spread really quickly around the world, in the month of January, you had 900 travellers from the Wuhan city to the city of New York, many who were obviously infected. And who intermingled with the New York population. So before we saw those huge breakouts in about March of that year, but by that time, the disease was well and truly transmitting within the community in that city for at least 8 weeks. 30 cities, 28 countries were permanently basically infected by the time the world was alerted to it being called a pandemic by WHO. But in particular, the first, I would say, beachheads for this disease were in the tourist hotspots in the Alps, ski fields in Colorado, basically tourist destinations. In northern Italy, it initially did start in the Alps, but one of the biggest, I would say, catalysts behind driving that huge migration from a disease perspective from China to Milan was obviously that manufacturing industry in northern Italy. So that's why it became so, it got a foothold there, and it spread very quickly because it not only actually formed a beachhead on the many tourist spots in the Alps in the northern Italy, but also through many of the workplaces very quickly. So by the time we get to February, close to the beginning of March, it was already beginning to move around in this sort of precarious workforce that we're well acquainted with now. So most of you will be well across the impact that this disease had in this country like Sweden. They've had a controversial approach to actually handling the disease, but one of the first cases that appeared there was a Uber driver from a migrant community. He had collected some returning holiday makers who were coming back from Italy, from the ski fields, and they were coughing for the entirety of the trip back home. It was a 45-minute drive. He was infected, and it took about 8 weeks for him to recover. Fortunately, he didn't pass away. Not the same could be said for the factory workers in Milan, for example, and the hotel staff in New York. Some of the first fatalities came from those sort of exposed occupations. By the time we get to March, obviously, most of you will now be well across the sort of impact COVID has had on a country like the UK. It's been pretty significant, but right at the epicenter of this disease in that country has been the migrant communities, particularly in London and some of the more working class cities around the northern part of England, and in Scotland as well, and in Wales. So migrant communities were over 3 times more likely than the white non-migrant counterparts to have lost their job during the COVID-19 lockdown. And what does that mean? Well, when they had that lockdown, it creates a sense of tension and stress within the community, particularly migrant communities that are working in precarious jobs, which are casual, which don't necessarily pay well. There's language barriers involved, and the consequences of that is you get what's called a desperate workforce. So lockdown occurs, they're still going to work. Those who are not, those who come down with symptoms will still turn up to work because they are working in pretty precarious jobs. They may have a fairly acrimonious relationship with the employer. They are not in a very friendly environment. And that's how the disease basically spread really rapidly. So when you see unemployment figures that are produced by lockdowns, that will have an impact on how the disease is spread quickly through the workforce, because it creates a level of stress within those migrant communities that cannot be controlled. So our political leaders can go out there and say, please stay home if you come down with symptoms. And in the UK, they did the same. But this workforce has spent an entire lifetime working in fairly acrimonious conditions, being retrenched, replaced, not being called up because they're on casual. So their intimate relationship is not with their political leader on TV telling them to stay home when they've got symptoms. Their intimate relationship is with their employer. And that's unfortunately how the disease in that particular country spread really rapidly. So you can see that migrant communities, 10% unemployment within a month of that country's lockdown, versus non-migrant communities about 5%. The minority ethnic groups in the UK account for about 34% of all the critically ill COVID-19 patients in the UK, despite constituting 14% of the population. So it's again another example just how quickly that disease spread through migrant communities and how disproportionate the effect was. The UK's public health investigation found that Bangladeshi residents in England were twice as likely as white Britons to die if they contract COVID-19, and other migrant groups face an increased risk of up to 50%. So again, it's not just about the exposed workforce, it's the lives they live. A lot of them have underlying health conditions. They, for one reason or another, have shorter lifespans, and I'll get to that in terms of how that is a major factor here in Melbourne. And the disease has an absolute monstrous effect on them. For example, in the UK, 2/3 of all fatalities were of people who reported having some form of disability. Now, disability is just not your traditional person with disability that can't move around or needs assistance to be mobile. It can mean a number of things, and it's all health related. It's all occupational related. So minority ethnic groups are also overrepresented in all England's COVID-19 deaths. And you can see here the stats in terms of per 100,000 of the population. African was at 83, other, which is mixed. That includes, Italians, Greeks, and so on. Caribbean at 78, Indian at 35, White Irish at 31, Pakistan at 30, Asian at 30, White UK 27. Takes us a while before we actually get to the mainstream of that population being white UK. So you can see the impact here is quite significant. 63% of the first 106 health and social care staff known to have died from the virus were from Black and Asian communities as well. And again, that's a pretty sad bit of statistic, really, because it's again, it's not just in terms of hitting exposed workforce in terms of those who are delivering people's Uber Eats or the couriering industry and so on. It's also in the healthcare system. In fact, by the time we got to the end of May, I think the overall figure was well and truly close to 40% of all those that have been impacted on come from migrant communities in the health sector. So it's a pretty significant statistic. Driving that, and this is where it gets quite depressing, only 44% of health workers from migrant backgrounds stated in a survey conducted by the Registered Nurses Association, stated that they had appropriate PPE versus 66% from the white population. So again, even that level of discrimination even permeates through the more professional sectors of their society. So over in the US, which all of us now are still watching with horror, as that disease is still escalating and they're about to hit their cooler months now. And I think we all know, unfortunately, know how that's going to end in the next 3 to 4 months. It's not going to be good. If you listen to all the experts in this field, they will tell you that that what is about to befall the US is going to be quite significant in terms of death and disease. So it's a very, very depressing state of affairs in that country. But even before we get there, African Americans in New York accounted for 92% of deaths per 100 in the city. Hispanics was 74, and whites 45. In Chicago, 72% of people who died from COVID up to early April were from the Black community. Despite only representing 30% of the city's population. Again, that massive disparity is on display here again. Black households are more than twice as likely to live in densely populated housing structures as compared to white households. And again, housing is not just about, the sort of traditional mindset that you'll have about housing, which is, large towers with compact apartments. It is also about density. Is also about the number of people that live in that household. So you'll find that migrant communities, whether it's in the US, whether it's in Sweden, whether it's in parts of Europe, in this country, in Melbourne, in particular in the western suburbs and northwestern suburbs of Melbourne, family structure is a significant factor when it comes to how this disease spreads. Black workers are more likely to live in multi-generational households, for example. So where older members live with younger members of the family, it is not strange to come across family structures in the US and in many parts of Europe where you have 3 generations under the one roof. And when we say the one roof, we're talking about a small home, not a large premise. So when countries go into lockdown, this is where the stress also compounds. So you're not just experiencing stress when it comes to occupation, you're speaking to stress when it comes to an ability to sustain lockdown. So even the members of that household that need to stay at home, they're not working, they face other challenges like staying in a very tight, small apartment for 24 hours a day is going to be very difficult. So hence compliance when it comes to social distancing and other restrictions is not all that crack shot, and is not actually a willful act. It's just that they are living in pretty cramped conditions, and lockdown is not really conducive to those sort of family structures. Black workers are twice as likely to live in households with 3 or 4 generations. And again, this is an important factor, and it's played out in northern Italy quite a lot. When Italy went into lockdown, those of you paid close attention to how that disease escalated in their country. They went into lockdown in early March. Cases kept on ballooning for weeks and weeks. And the situation got worse and worse for at least 4 or 5 weeks after their very severe lockdown. And that's because the young members of those families were still working, getting infected, coming back home, infecting 2 other generations. So you had weeks and weeks of that occurring, and the disease didn't stop until it actually infected enough of those family structures. The lockdown actually had a fairly limited impact in terms of controlling that disease in those family environments. The other factor, which is an important one, is obviously access to internet and other IT appliances and so on to keep people entertained, but also provide them access to the outside world. That's an important point. In this country, for example, in Melbourne, for example, the internet connection is at its lowest in the postcode 3047, which is in Broadmeadows, where some of the initial clusters of the second surge of this disease in this city appeared. So you have small, cramped conditions, lots of people living under one roof, hardly any internet connection whatsoever, and you're going to get a pretty stressed environment very, very quickly. And again, in terms of the evidence and how this community, pardon me, how this community basically works in exposed work occupations. When we started lockdowns in this country, and the media narrative was always about how people were struggling working from home. That narrative was no different in the US. And what was missed completely from those narratives at the beginning of this pandemic was the reality that migrant communities and ethnic minorities were facing every day, and that is that they could not work from home. That's not what their occupations permitted. And more importantly, and more telling, was that many of these migrant communities didn't have appropriate sick leave entitlements and so on. Most of you will be well acquainted with the sort of campaign that the ACTU in this country had ran from the very beginning of this pandemic, and that is the paid pandemic leave, so to speak. The reason they were campaigning on this space was that the evidence, even early on in this pandemic, was telling us that one of the key drivers of this disease spreading was people's inability to actually stay home because they could not afford to stay home. They could not afford to take hours off work. And I think decision makers around the world were very, very slow to understand this important dynamic. And again, you can see the consequences of the overall death rate. Yeah, although, yes, whites represent 39% of the first 2 million records in terms of cases. Hispanics, 31%, African-American, 19%. They're pretty significant figures because I think the African-American community only makes up about 14% of the US population. So statistically, they're always above in terms of their representation. And again, the same applies with the actual fatalities, unfortunately. The other driver, most of you again who live in Melbourne would be acutely aware of the sort of the horrific scenes that we all watched on our TVs or were personally involved in terms of trying to mitigate with Melbourne's public housing towers being locked down. Our medical professionals were well aware of what could potentially have happened in those towers if swift action was not taken. We can have a debate in terms of how that action took place and whether there should have been performed differently. But the reality was that if the disease was allowed to spread within those towers, the consequences will be what occurred in New York. And in New York, when it comes to public housing, you can see the disparity in terms of the minorities living in those public housing towers. And this is where it gets pretty grim. So most of those public housing towers, you can find them in Queens, Kings, in the Bronx. And you could see here the actual fatality rate in Queens, for example, represented by Hispanics and African Americans versus whites. Significant differences. Over 6,000 people in public housing residents in New York had contracted the virus, and over 1,200 had died by the time they got on top of the disease in New York City. So that's a fatality rate of 19%. It's pretty significant. And again, Staten Island's another impoverished area. Some of those boroughs in there, in that part of the city, are quite poor and have a lot of public housing for, apartments situated there. And again, same trend, African American Hispanics are always at the forefront when it comes to fatalities in that city. Bronx, same story. In some of the public housing towers, the fatality rate was up to 50%. In one or two of them, up to 80%. So that's how devastating this disease can be in what is fairly close, confined spaces where even the air conditioning systems are quite archaic, where you have a one central air heating system in place, and the disease can spread pretty quickly. There was very, very little effort at the beginning of this pandemic made by the city's authorities to actually implement any infectious control measures for those public housing facilities. So the disease was like a wildfire. We'll go to Europe now, where again, very similar story. In Norway, again, disproportionate impact on the Somali community in that country. Norway had a pretty good health response to this disease. To this day, they're doing pretty well. Sweden, very similar again. Significant disproportionate impact on the Somali and Afghani community in Sweden, and this is where it gets quite devastating from a research perspective. When you look at the demographic impact, yes, initially the disease was allowed to spread within that country. That country had a health policy of basically encouraging its citizens to stay home, work at home, not really had any severe lockdown measures in place. They didn't take into effect the precarious workforce, those individuals who had to work, and many of them work in aged care. And over half of their fatalities, they to this day have about 5,800 dead from COVID. Half of those are from aged care homes in a country of a population of 10 million. So devastating impact and spread by a precarious workforce that primarily lived in the poorest parts of Stockholm. Belgium again was had one of the highest death rates in the world for at least a good couple of months, and unfortunately, the driver behind that was the Turkish community. So a lot of Turkish migrants live in parts of Belgium. They are truly an underclass in that country, and again, COVID found its way into those communities and devastated them. And that's the thing about this disease; it's basically poured like ink over, I would say, a rough surface, and it's exposed all of these countries. I would say fairly poor and appalling approaches to treating migrant communities well, ensuring that they're employed in proper, safe conditions. They effectively, for decades, were a silent community for a lot of these within a lot of these European countries. France is the same story. Initially, the disease found its way to one of the most impoverished parts of Paris, where there's an immigrant population. Cases were almost double compared to the general population, in particular amongst the African community there. It was triple the cases and deaths when it came to people who what we would define as undocumented migrants. So we come to Victoria, and again, the most exposed workforce and households with the highest human density, coupled with lowest housing real estate, are located in Melbourne's west and northwestern suburbs. So for those of us who study demography, we started to get worried about this disease in Melbourne when we heard the first case. It was in the Faulkner McDonald's. So we knew that once someone had tested positive in that community, it was a precarious worker. We knew that that person belonged to a particular migrant community, and we knew that if the disease got a hold in these communities, it'd be very, very hard to control. The rest, unfortunately, is history, and we can see the consequences of it. The other factor here, and this is the more a fairly untold part of this disease in terms of why it's so devastating when it hits migrant communities, is that generally speaking, people living in poorer parts of Melbourne die a lot earlier. So you can see here, these are LGAs, life expectancy, median age, mortality by LGA. These are the top lowest, the bottom lowest LGAs in the state of Victoria. And you can see right at the bottom there, we have the City of Hume, Wyndham and Melton and Melbourne. Melbourne obviously is driven by those public housing towers. So there's significant underlying health conditions in these communities. They generally don't live as long as those who are living in more wealthy parts of Melbourne. Now, the disparity between these LGAs and the more wealthy ones is quite significant. So if you're living in Bayside, you're practically living 13 years longer on average. That's a pretty significant difference in a city of this size. So again, COVID will unfortunately find its way into those communities and hit them pretty hard. The new migrants that we talk about, there's obviously those of you who are listening tonight or watching tonight. There are two types of migrants in Melbourne. There are those who have arrived over the last 20 years and those who've been here for 40, 50 years. Both have been hit by this pandemic in very different ways. New migrants primarily work in precarious jobs. They are exploited. They are forced into situations where we've heard these stories where aged care workers are forced to work, on 4 or 5 different sites in 1 week just to earn an income. That, again, as I spoke about at the beginning of the presentation, creates a sense of stress within the community, where even if they come down with a cold, what they think is a cold, they will still turn up to work because they can't afford to lose the hours. Fortunately, some governments in this country have taken the necessary steps to compensate people for that loss of money. But again, that only will take you to a certain point, because there is other situations in those workforces where it's not just about the money; it's also about fearing that you never get that call again because you work as a casual, and you'll end up having to turn up and not to turn up because you've come down with what you think is a cold, and your boss doesn't ring you for any more shifts. So that obviously is a live problem. And you can see here that the aged care workforce predominantly lives in, well, guess what? The hotspots. So you can see here in Melbourne's north, Melbourne's west, and out in the Cranbourne Way in the Casey Council area. Unfortunately, that's again where we have most of the breakouts, most of the fatalities when it comes to aged care. So those new migrant workers, stressed, living in cramped conditions, lockdowns in place, limited internet connection, limited education, limited what I call social and capital influence, come down with COVID, turn up to work, go to St. Basil's, the rest is history. So they infect those aged care homes. Those aged care homes themselves, from a management perspective, there's a different story to be told there, but the consequences are now, I think Greeks now represent 20% of all fatalities in Victoria as of last weekend. That number may have changed, but I don't think it's unfortunately going to move all that much. It's a pretty significant statistic when the Greek community really makes up to 2% of the population in Victoria. That's one of the biggest, what I call statistical disparities between population and deaths in the world. So I showed you a number of ethnic minorities around the world in terms of the disparity between their death rates and their actual population within those communities. In Melbourne, the Greek community, unfortunately, is probably carrying the number one mantle in this space. So again, private aged care is typical of COVID-19 exposed industry. It's a precarious workforce, high proportion of new and young migrants. They're working across multiple sites, located in private aged care facilities that offer limited services for lower socioeconomic elderly residents. The disease obviously impacts the migrants that came to this country in the 1950s and 60s, my parents' generation. Again, that very unfortunate statistic, which I don't think will change all that much, 20% of all fatalities in Victoria are Greek. And although we only make up 2% of the population. And again, in terms of exposed workforces, these are the statistics in terms of the COVID infections in Victoria by occupation. So you can see the healthcare workforce is bearing the full brunt of this, and there's not a day where we don't see on our TVs every night the numbers being read out of more healthcare workers being infected. They're pretty significant. Aged care is nearly 1,000. I think the figure is now probably more in excess of 1,000. Schools, 630 again. That includes students, but also teachers. And again, I include schools in there because it is effectively the sort of, it offers up a same sort of level of exposure that a meatworks would, for example. When you go to meatworks, there's over 550 individuals in the state of Victoria who work in meatworks who've been infected. Warehouses, 439, childcare, 180, and unfortunately, as long as this disease persists, we will continue to see more and more of these infections in these workplaces. When we move from stage 4 to stage 3, the biggest challenge for our healthcare professionals in this state is to control breakouts in these occupations. Unfortunately, the disease is now well and truly within these communities, and although stage 4 isn't limiting the spread, the challenge will be to prevent significant breakouts within these communities going forward. That's it for me. Happy to take questions and answers.
Costa, can you switch over? Okay, Costa, thanks very much for that insightful presentation. A lot of food for thought there. As the questions come in, I might just kickstart off the questions. Look at those slides regarding statistics from New York, the deaths per 100,000 across the various ethnic groups. I noticed the Asian sort of contingent was even lower than the white contingent. What's the thinking behind that?
Yeah, so they generally, it's more about where they live. So you find the Asian population in the US is situated in other cities, more over in the West Coast rather than the actual East Coast. And they generally are not what you define as working in exposed industries. So they're more middle class. They're very similar to the Chinese community here in Melbourne. They're not, yes, they work in retail, they work in some exposed industries, but the precarious nature of what they do is not as severe as it is compared to the minorities that I explained.
Okay.
Yeah.
Thanks for that. We've got a question from Fiona Pepper. In terms of business closures in Melbourne, any idea how many are owned by migrant families?
That's a very good question. I would say quite a lot. And the reason for that is that the biggest employer in those hotspot LGAs that we talked about, so Hume, Greenbank, Melton, Wyndham, biggest employer now is not those large factory floors that used to occupy my headspace when I was growing up in Broadmeadows. They are a small business. So, we're talking about 38,000 registered small businesses in the city of Hume, who are now, a very significant portion of them are now shut down. If you go to many of those small businesses over in the Roxburgh Park Shopping Centre, for example, they're run by migrant families, predominantly by migrant families. There's no question about that. So, and those who are employed in there are migrants again. So we've had a compounding effect. Not only is the workforce that's been forced to work getting infected, the lockdown is having a disproportionate effect on those who are employed in small business. Their biggest employer of migrant workers in this state is small business. No question about that. So yes, absolutely disproportionate effect.
Communication and getting a message across has been an issue of this pandemic. And Tracy Scott asks, how do we engage in a more meaningful way with migrants whose second language is English? I mean, where have been the shortcomings in them?
I think the shortcomings are really in the economic space. So there was, at the very beginning of this pandemic, and we saw it in other countries, a lack of understanding that many migrants work in exposed work occupations, and they will probably tell you in detail that they are concerned about the disease. They're concerned about contracting it if they're younger workers going back home, infecting mum or grandmother, but they really have no choice. The media will always focus on the recalcitrants because it provides good footage for them, right? They always go out to, as they did today, to Dandenong and film a bunch of hooligans, flouting the rules, because, and they always go out, as they did on the weekend, to the Whittlesea market and pretend that migrants are not complying with the rules or social distancing laws because they're just, standing next to each other too much. But in reality, most of them understand the risk, but are unfortunately exposed by virtue of their work. The other challenge there from a health advertising perspective is many of these workers, they're like most people in Melbourne who are working in precarious occupations. They don't watch much TV because they don't have much time. They don't tune into the news as I would say, a person like myself does. So the challenge for governments going forward is to actually push that health narrative out to what I would say organic spaces. So in shopping centres, the Broadmeadow Shopping Centre here in Hume, even during the most severe lockdown, is one of the busiest. There are a number of reasons for that. For example, people use that as a place of recreation for their 1 hour. It's within a 5 kilometre radius of their home. They go there because there's potential Wi-Fi, because you'll remember there's limited internet for a lot of these households. These households also live in very cramped conditions, so they're using it for a bit of headspace as well. So if you're going to advertise, you should actually work out how to put advertising into those spaces. That's where you get them, right? So that's where they're going to be relaxed, open-minded about things, and maybe potentially absorb some advertising.
Yeah, the last slides you put up, they're really quite dire, actually. And we've got a question here regarding, especially those Greek figures and fatalities.
Yeah.
Is the political establishment aware of these stats? And what should be our Greek community response towards them?
They are, from what I'm aware of. I think the media, there's not much coverage of it. That's my gripe, my personal gripe, that yes, the fatalities are read out every day and the media will cover it, but the actual morbid statistic of 20% that belongs to the Greek community is not covered all that much. I mean, I do a bit of it through social media, but some other commentators do it as well. It isn't all that prevalent. What can be done in the future to avoid that situation? Because we've got to remind ourselves that the poor Greeks that got hit in St. Basil's, so I would say they're about 10 years. They're the first wave of migrants in the 1950s, early 60s. There's another group now coming. They're, in their 70s at the moment, late 60s, 70s, very big part of our population, our Greek community. They're going to enter these spaces. So what's incumbent upon us who can is to fight tooth and nail to make sure that whatever standards are in place in those aged care facilities, that they are the best in the world. In other words, we demand that conditions in these spaces are improved demonstrably to ensure this never happens again. Because if it's not improved, we don't know how long COVID's going to last, right? We've got to remind ourselves that in these aged care homes, many Greeks in the past have died unnecessarily just because the infectious control procedures, protocols in these places has been pretty appalling. They've died of the flu when it could have been avoided. Right? So we need to demand that our elderly are protected when we as Greeks have no choice but to actually put them in these care environments because of their declining health.
Okay. A question from Deb Valance. Do we have any evidence that paid leave arrangements have had any impact on the number of cases? So that was a measure used by the government, but can we measure its impact? Or
yeah, I think there was a statistic on the not necessarily paid leave, but there's the $300 that you're provided if you go and test and you're waiting for your results. I think 23,000 Melburnians access that service. And I don't have the actual LGA breakdowns, but I'll be shocked and horrified if the majority are not situated in hotspots, because they would be. So there's a very powerful statistical narrative there already present for us, that if you provide these reliefs for the exposed workforce, they will take it up. They will try to prevent getting sick, and they'll try to prevent from spreading the disease to their workplace and to their family.
okay, this I think is more a comment from Tracy Scotland. As a clinical nurse and a registered CTO, I always thank people for being tested and try to help, understanding that testing is a good thing for the community. So it's good to see. So, yeah. Yeah,
I mean, that's it's an important point, because one of my personal concerns is that there are significant groups in these migrant communities that are not going to get tested for various reasons. So, for example, in the Somali community, one of the biggest battles that some of the Somali community activists had at the beginning of this second surge or second wave within Melbourne was to convince people within the Somali community to go and get tested, particularly in the towers. Because we've got to remind ourselves that in Somalia, if you get sick, you get ostracized, right? Because there's no health system. So there's a stigma associated with disease that is deeply ingrained in some of these communities, and we need to appreciate that. And there's also fear associated with it as well. So people just won't get tested for fear, for stigma reasons, fear, and occupation.
Okay, I've got a question from Konsotidis. Given the natural tendencies and migrant communities, especially the Greeks, to interact and mix, does this make migrants more vulnerable to COVID, given that it's social expected to greet one another? And they're sort of hands-on and touchy-feely, aren't we?
That's right. And the beginning of this second surge was that, there was large family gatherings, and that's how the disease spread. Well, that didn't surprise me, and I'm sure it doesn't surprise many of you listening here tonight. That is, when migrant communities get together, they get together in a very big way. And so any education in this space needs to really focus on that as well. And that's going to be pretty hard, because that is a very ingrained cultural habit of all of us, and that is that we like to socialise with our friends and our family. Particularly as we head into the festive season. And it's, again, another compounding factor.
Yeah. Got a question / comment from Elias. I mean, if you look at some of those statistics and life expectancy from different suburbs, is it a class issue, and are we as a society don't want to accept it?
The answer is yes, absolutely. It's a class issue. It's, people living 13 years less than others in Melbourne. There's no other reason but they're poorer, their diets are worse, they have a tendency to smoke more. Before this pandemic started, I was posting up, Nick, and you would have seen this through my social media feed, maps of diabetes in Melbourne. And people at the time were saying, what are you doing? You've been an alarmist. I said, no. This is where the damage will be if COVID gets here, because if you bring these maps up in terms of where the most prevalent numbers of people who are suffering from diabetes, they are, again, in the hotspot LGAs, right? So, and we all know now that diabetes and high blood pressure is one of the major underlying health conditions that COVID exploits fully, particularly amongst people for about 60 years of age and older.
Still got time for a couple of more questions? Or
yeah, go for it. Yep, absolutely.
Okay, I'm just waiting for them to come through. Cos, from the data that you have or that you have access to, how do you see things panning out over the next few weeks before we reach 13th of September? Or what trends are you seeing that we may not be seeing? Or
So we're probably seeing, in my personal view is the only way we get on top of this disease when it comes to the hotspot LGAs is we perform mass testing. So at the moment, testing is voluntary. So if you have symptoms, you must go and get tested. It's a very good message. Most people that do have symptoms, go and get tested. In a lot of these migrant communities, that necessarily won't be the case. And I think one of the good things that this government did at the beginning of the second surge of the disease was the door-to-door testing. And although, that we heard stories about, people refusing to get tested. Well, if you test 50% of a particular postcode, that's a lot more than you're testing right now. I think on average now, if you come out to my area, which I live in Hume, I think it's about 80 odd people are getting tested every day. Right? That's, okay, statistically, by the end of the week, you've got many hundreds, but when you consider that this LGA has 230,000 people, that's a problem. So their biggest challenge will be expanding the testing regimen into workplaces that are exposed, having regular testing regimens in place in exposed workforces, and also having much more aggressive testing measurements in place in a domestic setting as well.
What's limiting expanding testing at the moment? Is it just resources, sort of human resources, or the capacity to test more?
I think it's human resources at the moment. I think once they get on top of the outbreak, they will then be able to actually devote resources to where it's needed the most. I think that is their strategy. I hope it is.
Yeah. Okay. All right. There's been a few comments. Let's see if I can see them all. Don't know if you can read them, Kos.
Yep.
Is there sentinel surveillance, random testing happening by the government? I haven't heard or seen any news items.
Yeah, no, I think they're only doing some sentinel testing as a part of sort of research projects at the moment. I know a friend of mine, he tested positive in March of COVID, and he went in, and he's part of that program. So there is a bit of that going on, but I don't think it's as widespread as in New York. I know New York has actually had a very big sentinel testing regimen in place, and I think they recorded that they estimate that 24% of the entire population has been infected. Very significant.
And there's a question about some of the data you presented, especially the US slides on ethnicity and working from home. Where did that data come from? And,
so CDC and their labour force statistics. And there's also a few other studies that have been performed in the country.
Yep. Okay.
If anyone wants to get that information, Nick, you can organise them to contact me. I'm more than happy to provide them more in-depth data that backs up those graphs.
Yep. Okay. All right.
Yep.
No problem. I think this sort of brings proceedings to a close. Also, just a reminder that next Thursday's seminar is on the Greeks of the Sudan. Just tune in at the same time. Kos, thank you very much. Unfortunately, the Greek Centre, we can sort of take you out for a glass of wine or something like that. But
ducks in there.
we owe you one. We owe you one. Okay. Okay. Thanks very much. Have a good evening, everyone, and we'll be back here next week. Much appreciated.
Thank you.